Genomic testing is very important before treatment in CLL. The most important genetic testing refers to the detection of deletion of chromosome 17p or mutation of the p53 gene, because this patient should not be treated with chemoimmunotherapy. I want to be clear, if you treat a patient with 17p minus or mutation of p53 is a medical error. That being said, there are several methods to detect 17p minus and mutations. Basically, interface fluorescent in situ hybridization for the 17p minus, which is the deletion of the short arm harboring the p53 gene, and molecular methods which detect point mutation in the sequence of the gene. And this has been standardized at the European level so that every laboratory receives a sort of validated method that he must apply to make an accurate diagnosis. Another important testing before treatment is represented by the study of mutations in the immunoglobulin gene. Those patients with the mutated immunoglobulin gene have a disease which originates from more mature lymphocytes, and this disease runs a more indolent clinical course, whereas those patients with unmutated immunoglobulin gene derive from transformed lymphocytes which are more immature and the disease a little bit more aggressive. In these patients, chemoimmunotherapy is no longer an option, and all these patients should be treated with novel agents. In the patient with a more favorable disease, chemoimmunotherapy may be offered to some patients, but with new data that's been published earlier this year, the new agent showed a superiority also in this setting, so that chemoimmunotherapy has little role today in the treatment of CLL, whatever the genomic profile.